Thank you, everyone. I'm excited to talk to you all this morning about correctional medicine and kidney disease. I'm a little sick and losing my voice, so bear with me in the next half hour. But I'd like to start with I can't advance my slides. So, there we go. Okay. So I'll start with the case that really prompted me to go down this journey and road. So I met a 50-year-old man who presented with subacute onset leg edema. He was hypertensive. His serum creatinine was 1, and he had 13 grams per gram of proteinuria. Serologic workup was negative. Biopsy showed membranous nephropathy, which was anti-PLA2R negative. And the plan was to do some age-appropriate cancer screening and potentially treat with rituximab. But the real challenge in caring for this patient, both in terms of all of the workup that was already done and in terms of moving forward, is that he's currently incarcerated in one of Washington State's prisons. So, I started wondering about the logistics of getting him to our center to provide him care. And what it looks like is patients coming from correctional facilities need to put on, orange jumpsuits. In his case, I think it was bright red. They are shackled or restrained and placed in the back of a van, and then sit in that bumpy van for a couple of hours to come to our clinics. Then they're accompanied by law enforcement officers as they walk in the doors of our hospital or clinics and deal with the stigma of people around him wondering about his situation or making assumptions about him. And then after his care, he has to go back in the van for a couple of hours and back to his correctional facility. And it seemed complicated, and it got me thinking about the landscape of kidney disease for people who are incarcerated and how to best optimize healthcare for this vulnerable population. So an outline for the next half hour. We'll start with discussing the intersection of incarceration and kidney disease. I'll describe the current state of correctional medicine and the services available to our patients. And I'll outline some best practices that we can strive for when caring for patients who are criminally legally involved. So starting with incarceration and kidney disease, it's important to clarify the difference between jail and prison because healthcare is very different in these populations. So jail is for people who are pre-adjudication, meaning they are awaiting trial or sentencing and are unable to post bail, or they are post-sentencing and serving less than 1 year. So this is for more minor crimes. And it turns out being a shorter term stay. So the average length of stay in King County Jail is 40 days, where in contrast, prison consists of people convicted and sentenced to more serious offenses and are serving longer sentences. So the average length of stay in Washington State prisons for people not serving life sentences is 32 to 36 months, and that's similar to national averages. There are many jails, and that's because jails are run by local governments such as counties or sheriff's offices. So the standards of care and the healthcare available varies quite a bit. For example, King County Jail does have healthcare services available, but there are smaller jails, like there's one outside Walla Walla that has an average of 2 people at any given time, and they don't have the infrastructure to provide on-site healthcare for them. Prisons are state, federal, or privately run, and the bulk of my talk will focus on Washington State prisons. And there's more consistency and oversight when it comes to healthcare for state prisons. In jail, there are fewer security measures, and in prisons, there's a range from minimum to maximum security. So how many people are we talking about? Right now, there are 1.9 million people who are in correctional facilities in the United States. About half are in state prisons, about a quarter are in local jails, and people are elsewhere as well. And when you think about 1.9 million people, that touches a lot of other people, right? Their loved ones and the other people in their lives. So this has a much greater effect. It's estimated that over 100 million Americans have an immediate family member who has been criminally legally involved. So even if we're not directly caring for a patient while they're incarcerated, they may be post-release or they may have a loved one who's affected by this issue. In Washington State, we have 28,000 residents who are in a correctional facility. About half are in state prisons, about a third are in local jails. We know that there are higher imprisonment rates from people coming from more rural counties, though it should be noted that most people released from state prisons are released to King County. So we are likely to see this patient population after release, even if we don't see them while they're in their facility. Incarceration rates have risen over time. This graph shows the rates of incarceration in Washington state since the late 1970s, where back in 1978, there were less than 5,000 people in our prison population, and that number has basically quadrupled over time. And it's not because crime rates are higher or we're living in a world that is less safe. It's because we are arresting and sentencing more people, and our sentencing times have increased significantly. And what makes up the demographics of the prison population in the state? Most are male, about 90% are male. And this graph shows the racial disparities in Washington state correctional facilities, where you can see that people who are Black, Hispanic, American Indian, or Alaskan Native are well overrepresented. And this is directly related to institutional and systemic discrimination in the state and country. And this graph matches up with what you would see with the rest of the country as well. With longer sentencing times comes an older prison population. 30 years ago, 2% of adults arrested were over the age of 55, 3% of people in prison were over the age of 55, and both of those numbers have increased. Now 15% of people in prisons in this country are over the age of 55, and it's estimated that by 2030, so just 7 years from now, a third of our prison population will be older than 55. And of course, we know that kidney disease is more common in older populations, so there's a significant overlap in risk factors for kidney disease and what our prison population looks like. Which brings us to other overlap that I found. Many risk factors for end-stage kidney disease are more commonly seen in incarcerated populations. So in addition to older age, we just talked about people of color being overrepresented in prison, and we know that certain ethnic minorities have a much higher rate of end-stage kidney disease, such as people who are Black or African American. In 2004, tobacco use in correctional facilities was twice as high as the general population, which it should be said in my particular patient's case, he stopped smoking when the commissaries stopped selling tobacco products. So I do wonder about the opportunity for an institutional correctional changes or corrections in our facilities and whether or not they actually might promote patient health. We have higher rates of substance use disorder seen in prison, along with higher rates of HIV and other infections associated with kidney disease, such as hepatitis B or C. About 3/4 of incarcerated people are obese. And once people enter a correctional facility or a prison, we do see weight gain. And this is related to the fact that people in prison don't have control over their lifestyle. They're told when to sleep. They're told when to exercise. They are told when to eat and what to eat. So, and the food is subpar. It doesn't follow any sort of sodium restriction. So good luck asking your patients to follow a low salt or low phos diet, or really any other diet that may help manage their kidney disease or other comorbidities like diabetes or hypertension. We don't know a ton about the rates of kidney disease in correctional facilities because this is an understudied population, but we do have a couple of surveys. So this is from the early 2000s, where people residing in jails and prisons were asked what chronic conditions they've been diagnosed with. And about 6% of respondents said that they've been told that they have persistent kidney problems. When you look at the other commonly listed chronic diseases, they are diseases that are often intertwined with kidney disease, such as diabetes, hypertension, heart disease, cirrhosis, and HIV. In a more recent but similar survey of people in correctional facilities, again, 6% people said that they had been told they had kidney-related problems, and again, had similar comorbidities associated with kidney disease like diabetes and hypertension. And one thing to note is the comparison of what respondents are saying to the general population. So higher rates of hypertension, higher rates of heart disease, higher rates of diabetes. And so in general, people who are in correctional facilities are sicker. They have more comorbidities or higher rates of comorbidities. The bottom line here is that justice-involved individuals are a vulnerable population who are at risk for kidney disease and its associated comorbidities. And this is the patient group that we take care of. Okay, so what does healthcare look like in prison? I'll remind you all that healthcare in the US is a constitutional right for people in correctional facilities. And this was a Supreme Court ruling, Estelle v. Gamble in 1976. And it focuses on our constitutional Eighth Amendment, which is a prohibition against cruel and unusual punishment. And the reason here is that a deliberate indifference to the serious medical needs of prisoners constitutes unnecessary and wanton infliction of pain. So no healthcare means that we are causing cruel and unusual punishment. I italicized the phrases deliberate indifference and serious medical needs because legally these two phrases have been very difficult to define and uphold. And so what this turns into is a great variability in the quality of care people receive between states and between different jails, because correctional administrators have very little oversight or funding in providing healthcare. So, and there's no real standards. So it can be a little wishy-washy what people end up getting. So at least for what we should be seeing in our prison population, what happens in Washington state prisons is that they do get health care, but that care is variable. Washington state prisons do have primary care services available, but specialty care is usually through the community, and that's how we'll be interacting with this patient population. Just because just because healthcare is a right doesn't mean that it's free. So for Washington State Department of Corrections, there is a copay depending on who's asking for the healthcare visit to happen. If a patient requests a visit or says they're having a medical emergency, they are required to pay a $4 copay. If it's for preventative care or if the provider requests the visit, there is no copay. And to put that copay in context, Washington State Corrections wages are 36 cents to $2.70 an hour. So it can be quite costly to see the doctor. Medications are prescribed and provided to patients. They can either be self-controlled or controlled by a corrections officer. And many of the medications we routinely prescribe, like RAS inhibition, antihypertensives, anticoagulation, are all on formulary. But if it's not on formulary, the correctional medicine providers will work with you to get whatever you recommend. So if a patient needs an SGLT2 inhibitor, tolvaptan, or in our patient's case, monoclonal antibody, these medications can and should be obtained. They have a right to these medications. It just might take a little bit longer to get them because there's some bureaucracy involved. So the best thing to do is really pick up the phone, call their provider in their correctional facility, and talk through the options and the best way to provide the standard of care that your patient deserves. Telehealth is a really helpful tool in this situation. I already described the kind of personal trauma that comes from, transportation to our facilities and getting care in our facilities. And there's also a cost involved in terms of staffing and transportation. So we know that telehealth provides improved access to care, both in the general population, but also for people who are incarcerated. It's cost effective. And there's some evidence to show improved adherence to care. I found two studies. One was on teledermatology and adherence to recommendations, and another one was on hepatitis C treatment, and there was improved adherence to blood draws and medications. I don't know how generalizable those small studies are, but it is encouraging data. But be aware that not all facilities can participate in telehealth. Washington state prisons can, but again, some jails do not have these capabilities. And remember that there's no other e-care availability. Most of our patients' charts are going to be paper charts, and it's not like our patients can send us my chart messages. So we do have to think about how to provide care. That's not all electronic. So what does dialysis look like in the state? We have one prison that provides dialysis, and that's Monroe Correctional Complex. Seth Thaler is the nephrologist who cares for those patients. It is a male-only prison, so I presume that women must go off-site for dialysis if they have end-stage kidney disease. We do have one incomplete survey of US states, and we know that 24 states provide on-site dialysis, 10 states provide off-site, and 10 provide both. And really the option for this patient population is hemodialysis. At UConn, they did a study teaching patients who are progressing to end-stage kidney disease to perform peritoneal dialysis. And what they found is that their participants were able to successfully perform CAPD, and secondary outcomes such as anemia management and peritonitis rates were pretty similar to that of the community. Unfortunately, PD has just not caught on as an option. And it's important to remember that someone's incarceration status should not preclude them from transplant consideration. Other institutions like the University of Buffalo have more experience transplanting patients who are in prison than we do, and they've reported 94% allograft survival at 1 year and quite a bit of cost savings in terms of less dialysis needing to be provided. But one of the challenges that they mentioned is follow-up. Patients after they're waitlisted or transplanted may transfer facilities and be unable to return to the transplant center, or after release they may not return for various reasons. And those barriers exist in terms of successfully getting patients waitlisted at our institution and at other institutions. When people are incarcerated, it's difficult for them to identify how they're going to have access to health insurance and healthcare, where they will go after release, and what sort of support systems they'll have in place after release. So there's a lot of work to be done in this realm. Now, release to community is a vulnerable time for this patient population. In the 2 weeks following release, there's a 12 times higher death rate, which is unfortunately related to drug use and cardiovascular disease. We also see a higher hospitalization rate and higher rates of stress and anxiety reported. There are also gaps in health insurance coverage. Right now, for Washington state prisons, patients can do the paperwork to enroll in Medicaid 10 to 20 days prior to their release, but that doesn't mean those benefits kick in right away. So to address this, luckily, there's Medicaid waiver 1115, which Washington and California are the first states to receive. Hopefully other states will join us. And this allows people to get Medicaid benefits 30 days prior to the release, so that there's no lapse in their medical coverage. I actually think the California one has options for 60 and 90 days prior to release too. And the requirements of this waiver is that patients have a case manager to help address any sort of barriers to care. Medications for substance use disorder must be provided if medically indicated, and patients must receive a 30-day supply of medications immediately upon release. So this waiver will hopefully address issues related to gaps in health insurance coverage, but it doesn't necessarily help with the psychosocial barriers to care that exist. Again, it's a very high stress and high anxiety time as people are dealing with the cultural shock of returning to the community and dealing with the stigma of their past incarceration. They're also worried about things like finding employment, ensuring that their housing is secure, and figuring out transportation, how to get to the store, how to get to our offices. They're navigating a healthcare system that they haven't worked with before. So they may need assistance in things like making appointments or filling prescriptions. So talk to your patients about the barriers that they may be dealing with, acknowledge the stigma they're dealing with, and offer any additional services that your clinic may have to help these patients in this vulnerable time. Another thing to consider is advocating for compassionate release. Compassionate release is a process that allows for the early release of or parole of some incarcerated people who are of advanced age, have life-limiting illness, complex medical care needs, or significant functional decline. And quite frankly, that sounds like a lot of our patients who are living with advanced kidney disease or end-stage kidney disease. So if you do see a patient who is incarcerated and in this situation, consider adding a discussion of compassionate release to your discussions around dialysis planning. And if it's appropriate, you can write a letter on their behalf. Okay, so finally, I wanted to take a moment to highlight some best practices for this patient population. The first and most important one is to communicate. Correctional medicine providers want to hear from us. They can provide medical records and background. And if we have any sort of question or concern about our plan we're recommending or the care they'll be able to receive, they can help guide us. And again, if they can get medications and the care that we recommend, and if they can't, they can work on facilitating transfer to a facility that can. Consider telehealth options, both to reduce costs and to improve care for patients. And for in-person visits, either in clinic or in the hospital, there are many things to consider. Our patients are accompanied by law enforcement officers whose job is to assess risk to the patient and to others, and they are not bound by HIPAA. So it's our job to maintain patient privacy as best we can. That may mean asking the officer to step outside the room. It may mean asking them to wear earplugs or step behind a curtain to maintain at least some semblance of audio or visual privacy. And if you get pushback from the officer, ask why and ask them to talk to their supervisor. It might just be that they're new and don't know that there's some flexibility here, or it might be that they have some sort of information about the specific patient and the risk that really can't be changed. Reconsider restraints. Our patients will be shackled or restrained, and that should never interfere with your exam. So you can always ask officers to move the restraint or work with them to find ways to minimize restraints. We can't provide specific follow-up or discharge plans, but we should provide some sort of vague guidance so our patients know what the care plan should be and can advocate for themselves. So that would include language like, after you're discharged, you should see a kidney doctor at some point in clinic, or you can say, you should get blood work done monthly. And if you haven't been seen by a kidney doctor in 6 months, say something to the personnel at your facility because maybe something fell through the cracks. And again, after release, do what you can to address barriers to care and connect patients with support services. On a bigger level, we can advocate for policies that ensure equity for patients, oversight of the healthcare systems in prisons and jails, and also improve access to insurance. So my references and some special thank yous both to Doctors Hall and Ng for answering my questions in preparation for this. And I wanted to highlight two people, Dr. Helen Jack with General Internal Medicine. She provides primary care for Washington State Department of Corrections, and Dr. Mark Stern, who formerly served as the Assistant Secretary of Healthcare for Washington State Department of Corrections and is a fierce advocate for this patient population. I've included their emails. They say reach out if you have questions about correctional medicine or if you have specific patient concerns that you'd like help with. All right, thank you.
Thank you, Lauren. Thanks for presenting on that topic. Questions for Lauren? There's a specific question from Megan about how follow-up for outpatient dialysis happens, how making sure that folks have a chair as they're discharging, if you have any information on that.
Megan, I'm sorry, I don't have information on that. All I know is that they don't have healthcare until they're released, and so I'm sure something has to come into place to make that happen. I just don't know. Hopefully, with the new Medicaid waiver, there will be more access, and people might be able to be placed more timely and in a more timely manner.
I'm curious about the access to peritoneal dialysis that you mentioned. You mentioned, peritoneal dialysis hasn't caught on, which is there's probably a lot more underlying that statement than you're able to go into. But do you know, I imagine it's not the patients that are not interested. Do you know anything more about why that might not be available?
I don't. I tried reading more about it, but honestly, all that's out there is this one study out of UConn saying, hey, it can happen. So it might have to, I'm sure there are many reasons why that have a lot to do with how it's paid for and potentially made up safety concerns. It's kind of my speculation.
Johan?
Lauren, that was an amazing talk. Thank you so much. I actually have a question about the compassionate release. Is there evidence that, and it may sound like a weird question, but is there evidence that, patients who have compassionate release have better outcomes? And the reason I'm asking this question is, once the patients are released, actually, there's a lot of uncertainty. Like, we talked about the Medicaid waiver, but then there's also the housing issues, and then getting the access to healthcare, and there's so many other variables. I'm wondering, like, is it better that they're released? It sounds like a weird question, but
no, I get where you're coming from. The short answer is I don't think there's data on that, but I can tell you more about the compassionate release process. So our involvement as physicians would be to write a letter in non-medical jargon to the warden of the prison saying, this patient has advanced kidney disease and these are the symptoms they're dealing with and they're not able to function well in a prison setting. And so I advocate for them to go home. And then the warden, along with a couple of other like a judge or some other judicial system, reviews that documentation from physicians, both in the community and in the prison. And they also review the discharge plan. And part of our letter should include what the discharge plan is or the release plan is. So patients do have to have secure housing and secure support systems to be released. And again, it seems like a very case-by-case basis. In terms of outcomes for quality of life, for longevity, I don't think there's that, but we do know that people who go home on compassionate release are not likely to commit crimes again or end up locked up again. The reoffense rate is quite low. So, in terms of safety to other people, it's entirely safe for people to be released back home.
Well, thank you again, Lauren. A lot of appreciation for really thoughtful talk in the comments there. With that, we can move on to our next speaker.